I would like to welcome everybody to this session this morning. We are in this session, Reimagining Comprehensive Musculoskeletal Care with Telemedicine and Other Digital Health Innovations. We are excited to have this session on this last day of our conference. I hope you all have been enjoying the Mid-Atlantic Telehealth Resource Center Conference. Today we have presenting with us Dr. Alfred Atanda who's a pediatric orthopedic surgeon at Nemours Children's Health in Delaware, and Dr. Lauren Hagel, who's a doctor of physical therapy at a larger hospital. So I want to thank them for their time and encourage you all to take notes and listen during their presentation. We will have opportunity for questions at the end of the presentation. If you are joining us virtually, you can use the app platform and do Q&A in the event MOBI. There's also an opportunity in the chat box through Zoom to do our Q&A. So thank you again for joining, and I'm going to turn it over to our speakers.
Great. Good morning, everybody. Thanks for a very nice, intimate crowd we have here. I promise I won't pick on anybody too much. I'm Alfred Atanda, and
I'm Lauren Hagel.
And we're going to talk to you about our experience with musculoskeletal care in telemedicine. So these are my disclosures.
Just me here.
Just her. So I always start off when I talk about telemedicine, people are always like, well, in orthopedics and musculoskeletal care, how are you doing virtual care? How are you doing telemedicine? And this is really where my journey started. For those of you that are familiar with the Delaware, Maryland region, my hospital, Nemours Children's Hospital, or Nemours Children's Health, is in Wilmington at the top of the state. And I had a particular patient back in 2015. He was an ACL patient, and his dad owned a store down in Rehoboth Beach, ready to move down to Delaware beaches. They're not as nice as the Jersey Shore. Don't make any mistakes about that. However, he kept asking me over and over, Doc, you gotta come check out my store, and this and that, and come down to Delaware beaches. And I was a little bit of a snob, but eventually he talked me into it. And it just so happened that, we did the kid's surgery on a Friday. It was that weekend, but I decided to go down. Me and his high school buddies went down there. And I couldn't believe how far it was to get down to Rehoboth. And they lived in I think Milton, the next town over, 10 miles from Rehoboth. But the point is, it had to be 2 hours to get down there. There's tons of high schools down there, tons of high school athletes that come from those places, and they would all come up to see me for various issues. And when I was down at the store visiting the guy, he said, Zach's doing great and blah, 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 but he's having trouble with his brace. And I said, what kind of trouble is he having? The dad tried to explain it, and he just couldn't really put it into words. So he put me on the phone with the kid who was at home, and he said, hey, doc, blah, blah, blah. I'm trying to figure out how to use the brace, and I still couldn't figure it out. So, of course, him being 15, he decided to FaceTime. He said, oh, look, this is exactly what's going on. I can't get. I said, oh, you just need to hit that red button and da-da-da-da. He's like, okay, doc, well, thanks. And I was like, well, while you're on here, how you feeling? Are you in pain? Are you taking your pain meds? Can you move your knee for me? Dogs running around. I was like, all right, well, have a good time. So we go, I go about the rest of my weekend. When I'm driving back, well, this kid's supposed to come back from his post-op visit in 2 or 3 days from now. But he's not going to get anything more than what I already just did for him. I'm going to have him move his knee, look at his wound, and ask him how he's feeling. So I know it's a weird story, but that's exactly how I got interested in telemedicine. Because I said, if this can apply for this one tiny little scenario, then it can apply for lots of things. Because what we do in orthopedics is a lot about looking at wounds, looking at joints move, looking at images. And that's 95% of all what we do. So I always share this story just to kind of put things into a little bit of the framework. So this is me being a nerd in clinic. I have all my little devices there. I have my cell phone, my iPad. That's not a real telehealth, that's my athletic trainer, but just kind of bear with me. I have the computer there. I have that Banco monitor to the left. That's where we look at all our images. I have a phone. So my point is, I don't have all the fancy bells and whistles and peripherals that they're kind of touting in the exhibit hall there. I just have regular stuff that anybody would have. And I'm able to do very thorough, very appropriate telehealth visits in that regard.
All right, so as Whitney introduced, I'm a physical therapist, and it's very exciting to be here with Alfred to discuss even the interdisciplinary ideas we have about digital musculoskeletal care. I am super pumped to be back in North Carolina. I grew up in Raleigh, so I'll be headed there this week and getting lots of hush puppies and party, where it's the best. Nowhere else does the same. I also graduated from the University of Kentucky with my undergraduate, and then from professional school for physical therapy. Go Cats. State nation. Big nation. So also been great to network and get to know other fellow Americans. And I'm currently living and working in Manhattan, where I had previously had a passion for pursuing telehealth as a professional, really right prior to the pandemic. And then my efforts towards actualizing that actually got sidelined because I ended up on the front lines of the pandemic. So it's really exciting to refocus at this point. But during that pandemic time, I ended up engaging in telehealth. So I'll talk about that a little bit later in the presentation. But along with what Alfred was explaining with the access to care, the distance, the efficiency, all of those aspects, I was noticing at the time I was in work, one of my jobs was a home health provider. And just the time going between visits on subways, different neighborhoods, it was really hard to accomplish a lot in a day. And telehealth was great for me and patients that were on wait lists to be seen so that we could get more clinical care done. So this map here kind of exemplifies that concept at large in the US, where it's not all the same in each state and each region as to how many PTs exist per the general population. There's a lot of disparities, which for me says this is an incredible opportunity for us to reach these areas that we were not formally reaching with digital access. As many professions now do have for licensures, physical therapists have a compact. Of course, not all states are part of it, but a lot in this Mid-Atlantic region are already participating, which is very exciting to see. Hopefully, continue to grow.
So we talked a little bit, I'm sure you're familiar with and have heard a bunch of these definitions throughout the scope of this conference, but mainly telehealth versus telemedicine is something that comes up a lot. And at least the way our institution and myself thinks about it is, providing telehealth is more kind of like educational type services with remote patient monitoring, things where you are gathering information but not necessarily constantly interacting with the patient and providing medical advice. Whereas telemedicine is more kind of what you think of as a provider of some sort, engaging and interacting with a patient, going over images, going over studies, going over labs. We talked real briefly about the benefits and advantages. Again, you all are well versed with this. There are patient level benefits and advantages. There's hospital department level benefits and advantages. Sorry, some of the wording is cut off there. Basically, for the patients, we talk about increased satisfactions, less waiting time, and for hospitals and departments, we think more about decreasing resource utilization, decreasing waste time. Disadvantages, you have to think about patient preference. Some people just don't do it, they're just not comfortable with it. From a hospital department side of things, I think billing is the biggest issue. A lot of this has been catapulted during the pandemic, but as we know, some of it will go back to what it used to be, and there will be much concern. And from a provider standpoint, some providers are comfortable with creatures of habit. I talk about my own profession in orthopedic surgery. It's hard to get our folks to do anything that doesn't involve directly seeing a patient in clinic or doing a procedure. Anything out of that, a lot of us just shut down. So we talk about, for all telehealth initiatives, endeavor specifically for orthopedics and musculoskeletal care. These are the big five I talk about. What you just should consider: practical matters, building licensing, legal questions, hardware, software options, looking at the different types of patient populations, and the different platforms that you might use.
All right, so to get into some of the published literature on the effectiveness of tele-PT specifically. There are some great studies that have already come out. The first one is from 2019, and it was from a group at UC Irvine, and it was published in JAMA Neurology. It was a group of quite a few different disciplines, neurologists, PTs, OTs, and other PhDs. These professionals were able to do a randomized clinical trial on comparing post-CBA rehab for upper extremity motor dysfunction specifically, with a portion of the patients fitting this criteria completing the rehab in person in a very traditional model, and then the other portion completing it at home using digital intervention, all having the same dose of the therapy. So they tried to standardize as many components as possible to compare. It was interesting to me in the study, they were able to mail or deliver different implements and tools for the patients that were completing the therapy at home. Some really fun interactive games that they set up for them. For instance, like a keypad or like a piano kind of tapping, a joystick and control for different wand-related simulator, like video driving games. They had just like video kind of examples that they could mirror of reaching and manipulating objects, things like that. So, this video gets quite into the details of it, but all that to say, the comparison of the outcomes was really encouraging. They used very quantified outcome measure pre and post the Feeble-Meyer, and the upper extremity motor gains were pretty consistent. There wasn't a huge difference between the two groups of in-house and, well, literally in their homes, and then the rehab setting. The next study is discussing the validity and reliability of internet-based physiotherapy assessments. I think this is a big question that people had. Can you really properly identify the problem, especially in a orthopedic setting? And this talks a lot about a particular functional movement screen, FMS, that you all may have heard of. It lends itself well to observing someone's movements versus being hands-on for them. So, of course, we want to utilize our strengths here in a visual assessment manner. And this group did a systematic review of studies that fit a very strict criteria. They whittled it down from over 400 studies to just 9 that had really excellent concurrent validity and inter and intra reliability. And within those studies, they found that telehealth was equal and in a couple cases even better in the outcomes with the assessments. However, one caveat was it was great for identifying, and measuring pain, strength, range of motion, swelling, balance, gait, and other functional mobility measures. However, there were a couple limitations that were a little bit more specific, like related to scar status and related to lumbopelvic posture and a couple other niche things like that. So not to say that we don't have any limitations here, but just this was helpful knowing some of the areas that's actually been shown to be quite accurate in our ability to assess. And I think that's one of the biggest concerns I've heard, aside from the lack of the hands-on care, is the accuracy in repeated assessments. So then the final study I've chosen to highlight is about, it comes from a group in the UK of researchers working in the primary care space. They also did a systematic overview, and within the current evidence, they had marked up to 4,000 studies, and then they weaned that down to 146. Also with very strict criteria, inclusion, exclusion, and quality, and all sorts of measures to determine. But at the end of the day, they were able to conclude that management of 5 most common areas of musculoskeletal pain and dysfunction, which was low back, neck, shoulder, knee, and then they chose the 5th one as like a multi-site pattern to be effectively managed with telehealth. And, as we know, with musculoskeletal pain and dysfunction, that is the leading global cause or source of functional disability. So this is a huge deal. A lot of people don't have the luxury, or they're not as savvy to know someone like health, or to go specifically to a specialist, and they may approach their primary care for help first. So we want to make sure to include that.
So getting into the nitty-gritty of how you can really create a musculoskeletal telehealth service. First things first, you have to look at your patient population. And we did this. We had about 1,000 visits over a 6-month period, just as a little QI project, and really wanted to see the types of patients that we're seeing in general. So I broke this down in this little pie chart. See the types of patients that come to the office. You can see about 1/4 of the patients are brand new sports med patients versus brand new orthopedic patients, and a bunch of them are follow-up patients. So then after doing that, I looked at all of those patients. It took quite a bit of time to sift through their charts. And I just said, okay, what percentage of those patients could I have reasonably done a virtual telehealth with and able to provide good care, answer the questions, and that sort of thing. So up to 4, sorry.
Was that on your very first, was that your initial visit with them, or was this on subsequent visits?
These were all comers. So some of them were post-op, some of them were brand new patients, some of them were follow-ups. So of all those patients I listed previously, up to 40% of them I thought telehealth would be possible, and about 60% of them I didn't think it would be that. This was just me being subjective. And then when I broke it down into the percentage of patients where I thought telehealth was possible, you can see that most of them were either post-op, follow-up, or sports medicine follow-up. 0% of them were brand new orthopedic patients to our department. There's a certain subset of patients that are actually new sports medicine patients. So these are patients who are already in our orthopedic department, had a knee injury, shoulder injury, were seen and evaluated by one of my partners, and then referred over to me. So they are a brand new sports medicine patient, but they're not necessarily new to orthopedics. So it's hard to find somebody completely off of the street and just do a telehealth visit, but a lot of my patients come from my partners who don't treat sports medicine patients. So in terms of patient selection, so those were types of visits. So now this is patient selection. So post-op, simple follow-up, MRI review, and surgical discussions are the top 4 types of visits that I thought would be best for telemedicine. Oh, sorry.
Sorry, just with the patient population, I'm assuming, since it's sports medicine, I'm assuming we're age group wise.
So I'm in a children's hospital, so everybody's 21 and under.
21 and under.
Yeah, but I mean, this could apply to adults as well, but this is just my personal experience. So MRI review and surgical discussion is huge. I have a few slides much later at the top that will go through that. But sometimes some of these patients are brand new to us. So somebody will have it worked up, they have an MRI, they were seen by an adult orthopedist, would prefer to come to a pediatric specialist. They'll get a hold of me either Facebook or Instagram or somehow. We'll get their MRIs uploaded, and then I'll look at their MRI, and then I'll do a virtual visit, go over their questions and concerns. So by the time they actually show up to the clinic, everything's already been done. So they just kind of come in, we examine them, and so it really does facilitate things. So MRI review and surgical discussions are huge for that. So this was our experience. It was our first 120 patients or so, basically looking at our telehealth patients. And we kind of compared them to a subset of in-person visits during that same time period. And basically, we want to look at the time and cost savings and satisfaction between cohorts of telemedicine patients versus in-person visits. Again, everybody was under the age of 18. It was a 1-year study period. We had our secure platform. Back then, we were using video, VID, Blanco. Now we've transitioned to American Well. But we had time and cost data that came from our department for telemedicine and in-person visits. And I administered a quick satisfaction survey. The results, basically, like I said, majority of the 120 patients were post-ops during this time period, because you can imagine they lend themselves very well to telemedicine visits. There were surgical discussions and follow-ups as well. When we looked at the timing, so total visit time in person, so the time you check in at our PSR desk to the time you check out, 68 minutes. Whereas telemedicine, the time you log on to the platform to the time you log off, average 17 minutes. So you can see there's a big, huge discrepancy there. For in-person visits, we kind of looked at, well, during that 68 minutes, what were you doing? You can see about half the time you were just waiting. And the other half of the time you were being seen by myself or another individual. And when you talk about the time that they spent waiting, well, who were they waiting for? What were they waiting to do? So some of that was check in and check out. But a lot of it was just waiting for me. You know, they go through the rigmarole, they get checked in, they get their vitals, they get the PA or resident, they go over. Most of the time they're just sitting there waiting for me to do other things. And when they're being seen, you can also imagine that most of that time is spent with me. Whereas a telemedicine visit, it's interesting, of that 17 minutes on average, 15 of those minutes were spent with me. And about 2 of them, I wouldn't even say waiting, they're probably just logging on to the platform and they figure out the password and all that sort of stuff. But the bottom line is most of the time that they spent during a telemedicine visit was with me. And when we look at the percentage of time spent with the provider during a telemedicine visit is 88%. Whereas an in-person visit, it's only 15%, you know? And it's very interesting because you get up, you go to the doctor, you take your kid out of school, you take time off of work, and only 15% of that time that you spend is actually spent with me. And that's during the visit. That's not the hour and a half to drive there, the hour and a half to drive home, half an hour to corral your kids and get them out of the house. I hate taking my kids anywhere, let alone go to the doctor. So you can imagine how much freer these people feel when they can do these virtual visits, get FaceTime with the provider, and it's not so disruptive to their lives. And this is just that satisfaction survey again. You know, did people like it? Did they think it was easy? Did they do it again? Did they recommend it? See, generally, they feel very good about it. We looked at the cost. So we look at labor costs, travel costs, and miles traveled. We can see in-person visits, the labor cost of all the people that touch the patient on average is $114, whereas telemedicine for that amount of time period was just me. So that's my labor cost associated with that. Travel costs, you can see there's no travel costs associated with telemedicine, but travel costs of a patient in person is about $50, and miles traveled around $85 miles, excuse me, around for all those patients that we saw.
Did you just calculated that?
Yeah, it was like AAA cost data that we found. So the amount of money per mile that it costs to operate a vehicle. I mean, it's a very rough assessment.
Oh, sure,
That
sure.
doesn't include tolls and stuff from McDonald's and all that other stuff.
Yeah.
It's just a very rough look. But the bottom line is, you can imagine, it doesn't cost anything. And this, yeah, sorry.
Real quick.
No,
Did you
please.
collect any data on difficulties of accessing the application and being able to get in? Like, did they call in for support?
So they had like a telehealth administrator help them log on and download the app prior. So they didn't just have to do it on their own. We had a little bit of an IT support team dedicated to telemedicine. That's a good point.
I'm just thinking of cost because that is a patient touch point.
It is. And at our institution, it was already there. The infrastructure was already there. But yeah, there is a cost to that I didn't necessarily have.
Yeah, no, this is great. I just was
But
wondering
yeah, it's a
how
good
easy.
point to think about.
Yes, yeah.
Did the families, did you have any issues with regards to this network? I mean, so was it cellular, did they ever have Wi-Fi?
Oh, yeah. So,
Connectivity?
yeah,
or
that
is it
same
no?
IT person would link up with them the day before, about 10 minutes prior to ensure that they were on the right signal. They had different testing things to ensure that the signal was good. And, you know, some people wanted to be on cellular, but they always encouraged them to be on Wi-Fi at home. You can imagine people with their cars and stuff didn't work out very well, but they did their best to ensure that, yes, all of those people did have access to some sort of laptop. And this is what we found, you know, improved efficiency, cost reduction, streamlining resource utilization, all the while maintaining patient satisfaction. Some of the limitations of this very brief study that we did, the patients weren't randomized. They were just the first 120 telemedicine visits that I did. We didn't really compare the control patients versus the telemedicine patients in terms of satisfaction. The telemed patients, cost savings, and were rough estimates. Satisfaction surveys were anonymous. They were basically me administering it to it. There's some bias with that, but research assistants or anybody to follow up. And the cost savings may not be generalized. This is one small little town and a small state.
Great. So I would like to highlight some of the areas of opportunity. You know, like Alfred, my greatest passion personally within physical therapy has been orthopedics, sports medicine, and that includes everything from pre-op, post-op, and even non-op. And the bulk of my career has been in private practice, outpatient orthopedics, sports medicine. I have a lot of experience there, and I think that is what a lot of people think about when you transition to the telehealth model or even a hybrid telehealth models, kind of structuring your visits to simulate what those outpatient visits would look like, which is a really fantastic utilization of digital care. But as physios, we do so many different things, and I really want to also mention that I speak not only for the physiotherapists out there, but also for just rehab professionals as well, whether that's OT, speech, and there's many extensions within that. But I also speak to any movement-based service. So whether that's in the health and wellness space, yoga, body space therapy, or training, coaching athletes, there's just so many things that really relate to being able to administer care that involves need for movement. So hopefully this can also extend to those. And even for physicians who might be limiting the aspects of a physical exam because it's a little bit more awkward, maybe but in addition to those kind of standard outpatient models for telehealth, there's a lot that can be done with school-based care. I think about this a lot where I'm currently working in the acute care setting. There's so much opportunity for elective surgery, but also post-discharge, whether it's post-surgery or post-general admission planning level. They do this a lot at hospitals, of course, especially, I ever hear a lot of the nurses following up on care plans, medications, things like that. But I think there's so many more opportunities for, preventing readmission. So safety of patients, making sure in terms of their fall risk status and how much they would be getting in and out of bed, things like that. So there's a lot of great exciting potential. Speaking of fall risk, there's the geriatric population, something I thought about a lot as well during my time working in home health in Manhattan was not only the time-consuming nature of not having as many cars and a lot of traffic and subway, was also the fact that not everyone was very mobilized as they were getting older. It's not super easy. There's not elevators everywhere for subways, and it's not easy to get further than someone's block or even their 5 or 6 flight walk-up apartment. So they might be homebound just because they can't do the steps. Whereas maybe someone in a different area that didn't, had a home in a car could actually not be homebound. But that's another example of where not only on these geographic deserts of people that don't have good access, there's people that are more homebound that really could benefit from these digital services. So there's a lot that can be done there with even assessing someone's actual living space, identifying like if their rugs are loose, they need grab bars, they can literally walk you through it versus having the time and resources of somebody kind of do that some kind of assessment. There's a lot of opportunity with workers' comp, working with injured individuals there. That's a huge industry that we can work with. And then the last 3, I'm going to get into a little bit more detail, some of more of my personal experiences with telehealth and some of my passions as well. The last 3, pediatrics, wellness-based, PT, and chronic pain needs. And a lot of these different things here can go into a hybrid model, just vary so much on the different institutions. But so to dive into those last 3, the first of which pediatrics. So while I was in New York and the pandemic hit, I was working for the DOE, school-based therapy, in addition to some of my home work. So these pediatric clients were transitioned immediately. We started using Microsoft Teams, and it was quite overwhelming for a lot of my coworkers, and that actually got me interested in sharing what worked for me, because I realized not everyone was super pumped about the opportunity like I was. And thinking about, in any medical profession, talking to a young child across the screen is a little bit daunting, and they can be a little bit tough to control. So one of my favorite approaches is with storytelling. It's just a really awesome way, of course, of engaging a human, let alone a young human. And it's a wonderful way to get them involved in that patient-centered care, and thinking about how they can enjoy the experience without thinking that they're going to do like 10 reps of, moving arms and legs. That doesn't really go well. So I like to try to think of my own ideas and opinions, and then kind of offer them some ideas, but also ask them to come up with some. So I've put here's some ones that I've been doing with some patients. And then here's a little example of what that can look like. This is on the right-hand side of my columns, one of my actual patients, of course, up to their face for privacy, but going through this example of the hiking mountain. He really liked the outdoors, and this was one of his favorites. This is a 5-year-old, and we had to first jump over the rocks at the base of the mountain, and we had to use some mountain climbers to start climbing it. Then we found some logs, we had to do a plank like a lot, and it's rolling like a lot, and then we walked across the bridge while we were on the bridge, tree poses, bear crawls, crawling like a worm or caterpillar, butterflies, all the nature and animals that we encountered along the way. So as you can imagine, it didn't feel like therapy at that time for the patient and for me, quite honestly. It's fun to have an escape too. And super engaging because, the attention is definitely a big barrier. And you have less control from across the screen. You can't really enforce to keep the kids accountable from afar. It feels very disempowering at times. So based on that, I found personally coming up with a couple of ground rules from the get-go, just identifying those with the patient and their parents, having child stay there, because if they left, it was game over. There's nothing I can do. And also the siblings, making it a very focused experience, a happy experience. And then the device touching, that was something from his personal experience. That was one of the biggest issues. As soon as their fingers got the screen in their tablet, they would shut it off somehow. And then, again, blank, and then what do we do? So a lot of time wasted in a lot of parents and things like that. So, of course, every provider makes up their own methods to their madness, but the point is just having these established was super helpful. Again, with attention span issues, I found that trying to utilize some time management resource strategies was even more important on a digital platform than in person. So really making the effort to be intentional on scheduling an outline and sharing it with that patient of the components of what we're planning to do that day, so that they can really be thinking through what that would look like, and then updating them whether they're using a visual clock or just explaining to them strengths and asking what we work with that. And then I ended up consulting with an OT on this last one because a lot of the transitions are difficult for some children, and just using certain verbiage like first this, then that was super empowering for me and the children to get some of these standards pursued as well. So moving into the next area I want to highlight about great digital opportunities within rehab. This is the wellness aspect. Alfred is passionate about wellness and quality of life types of care as well, and what he does. We can really get on the preventative side of things as physios in mobility screening and trying to assess out if there are potential issues that will be coming up for people, especially the young athletes that might be so athletic that they can kind of get by for a while until all hell breaks loose. And so even before seasons, things like that. I've done some research with pre-season testing, and I think that's a really exciting area that we have more in general with. There's some different methods of mind-body awareness teaching with physios. There's different trains of thoughts, like Feldenkrais, or just ways of learning through movement that bode really well for this digital screen. And then just the opportunity to triage as well, whether it's referring someone for further consult for potential surgery, certain concerns, having a second look, but then other, wellness professionals, whether that's the more behavioral, mental health or psychological counseling. Of course, there's a lot of pain, there's depression and anxiety, nutrition, massage therapy, yoga, meditation. These are some areas that I encourage patients to pursue as well. That's some of which can be done in digital medicine. And then the last category here that I want to talk about is chronic pain. We know that's a huge issue globally, and hear a lot about working through the opioid crisis and ways that we want to try to help people manage it conservatively their pain. So it becomes a problem when that pain persists for so long that the body takes it on a centralized process with CNS. And it becomes on this feedback loop where the actual tissue has healed, but they're getting these nociceptive inputs in their brain and having a real pain experience. So in the clinic, I've found the best interventions have been hands-off. So that's why I think this is a great opportunity. It's oftentimes patients that really have a hard time getting out of chronic pain have correlations with a more victimized experience, whether that's a motor vehicle collision where something happened to them and it was very jarring, emotionally and physically traumatic, and then another victimized situation like physical assault, or whether an injury happened on the job where it just felt like it wasn't even maybe at their own volition or at their own space. And then, of course, heaven forbid, they're driving for their job and they get, in a collision or they get assaulted at work. I've seen where those combinations make it really tricky. So there's a really interesting study that I have actually shared with patients before. It sounds ridiculous, but I put a little clip on here. It's neck pain and demolition derby drivers. So they have these monster truck things, and I guess people get excited about this sort of thing. It sounds horrible to me, but these participants in these demolition derby, the drivers, they're like hitting things left and right. So you think their neck must be horrible. They're like probably just suffering. And I'm not saying that they don't have any neck pain or dysfunction, but they compared with standardized measures. They compared their pain and dysfunction experience to those that had like a very standard motor vehicle collision. And it's really fascinating that these demolition derby drivers had far less issues. So it taps into some of the empowerment and the way the brain is so complex with managing pain. And when people are, you could also argue that bracing for it too might help, but just the mindset is a big deal. So some of what I found helps these people is talking through it. Just even talking about imagining an experience that if someone were to hit their neck or grab their wrist like their boss did or something like that, what happens in their body in that moment. And it's amazing. Some people say, it starts to hurt right now. And then they realize, that's interesting because nothing happened. And they start to understand how this whole process works. And then we talk through it. And then there's, kind of exposure therapy that we can do. So kind of getting into the point I have about implicit versus explicit. So really getting people to just stop thinking so hard about it and doing natural, more reflexive movements, whether that means they're just tossing the ball up and down. Maybe they were just so afraid to move that wrist that got cold that they ask them for range of motion, it's like 5-10 degrees, but then they start throwing a ball and it's like, no problem. So it starts to feel a little bit more natural. There's a little bit more of a synergistic muscle activation, and then we build on it. So starting simple and creating very achievable goals. All these things can really be nicely done on a virtual platform. Another aspect I have a photo of here is mirror box therapy. This was primarily researched with treating the phantom limb pain. So a great example of where the the actual body part isn't there, but they are experiencing pain. This is a similar phenomenon with some of these centralized pain processes. And so being able to see that limb, so to speak, it really helps to rewire the pathways in the brain and use that neuroplasticity in a positive way to start reinforcing that they're not experiencing pain and it's going to be okay. And I've actually even done therapy with people that have their limb, but that is their impaired limb. So that's their, let's say their boss pulled their left wrist. So they have their right wrist reflected. So they're viewing the mirror where it appears to be their left wrist, but they're actually moving their right. And while they feel pain in their left wrist, that's sitting in their lap, because it looks like their left wrist is moving, then they start to remind themselves, no, it's okay. And then we build on those principles and do more things and get more aggressive and reconstruct them. So the last area of kind of general wellness concept that I wanted to highlight, I personally have a bit of a background in oral facial pain treatment. A lot of that, of course, includes TMJ disorder. But it can extend far beyond that. But there's a large correlation with trauma and even sexual assault with the population of individuals that suffer from oral facial pain, more so than the average percentages of assault. So there's a similar component of wanting to empower these people and work within some of these digital spaces that lend really nicely. So there's beyond some of these like corporate and standard opportunities that I've discussed, there's some just more thinking outside the box opportunities as someone that does movement-based treatment. And some of those could include whether you're coaching, performance athletes, working just, weekend warriors that are passionate about anything that we do, just working with corporations. There's a lot of companies now that have started to do this, where they're providing economic consults or movement ideas for the workplace to kind of work around insurance. I think it's really genius. There's a way to have someone contracted in and they care for their employees versus those employees going out and then having to use insurance. And from a cost analysis, it seems to work really nicely for the corporation. And then there's a better relationship, so to speak, hopefully with some regular therapists that these patients or employees know and trust. And then there's blogging, websites, and then any kind of on-demand consulting work. So lots of exciting opportunities. And whenever I hear people say, how could you ever do physical therapy from a virtual platform? These are the things that I think some resources that have that.
Have you started using any type of virtual reality for pain management?
I haven't personally, but I know that people do, and it's really cool.
It's very cool.
Yeah, if you do have experience with that, I'd love to hear.
Yeah, so we actually work with a provider. They're focused in PT right now, and it's XR Health. And so their platform is they can do remote treatment monitoring, and they kind of figured out how to make sure the visits are happening at home, but they see on the screen what the patient sees in their headset. And so they have two headsets that they use. One that's for the clinic, that's for the Pico type headset that's larger, or the larger size. And then they have a smaller one that looks more like classes that have circles with the side that go home with the patient for the virtual visits. And they have done some studies with VA hospital on pain management with their platform, and they're seeing fantastic results with pain management and reduction.
Just all age groups?
Yes, all age groups. So, and then there's a couple out there that are focused more younger adults, children. But just wondering as you're continuing, I mean, I think it's great doing this, but as you're evolving in some of those platforms, which I can give to you, if that's what there's a number of startups out there now. XR House is really
Is any of that billable?
So it is. So XR Health actually, they can bill, I don't have it all in my head right now, but the remote treatment monitoring, it has to be 6 sessions per. And so they're able to track that. So you can bill once a month for remote treatment monitoring, and then we do have the telehealth, tele-PT codes, virtual codes on the fee schedule now. Added to so they're able to bill for that.
That's great. Thanks for sharing this. There's already that monitoring of these devices for the lead as well. So making it a meaningful digital experience for everybody, just for all.
Absolutely.
Yeah. It's awesome. Thanks for sharing.
Sure.
I'm sorry if I could just interrupt right quick. If you don't mind repeating the question from the audience, just so that we can hear online.
Sure. It was, I don't want to misphrase it, but regarding virtual reality.
Virtual reality.
And it's specifically for pain management.
Yes. So there's multiple platforms out there for virtual reality. So it's just asking if currently they're using any virtual reality platforms for pain management, tele-PT, virtual visits, etc.
Okay, switching gears. So this is some of the things that are really near and dear to my heart in orthopedic telemedicine. So we've kind of talked about traditional, tablet, doctor to patient kind of stuff, but this is some of the outside of the box things that I've kind of piloted over the past 5 years at my institution and also outside of my institution. I kind of categorize things into 3 big buckets. So we do have provider to provider modalities. Then we also have direct to consumer modalities. And then lastly, we'll talk about kind of asynchronous video technology modalities. So providing information via video, usually YouTube, for patients and other providers that they can digest. So sports sideline coverage is the big thing. As a sports medicine surgeon, for those who have watched professional sports, you see these orthopods in the field with their $3,000 suits running out, taking care of these high-profile athletes, which is all well and good, but it creates 2 problems. So number one, as an actual provider, it takes a tremendous amount of time and energy to physically cover athletic events. And number 2, it creates kind of an access to care issue because there's only a certain amount of orthopedic providers, sports medicine providers that can be at these games and events. So we tend to gravitate towards the big ticket sports like football and basketball. And we also tend to gravitate towards big ticket people, right? So professional athletes, collegiate athletes, and for as a pediatric orthopedic surgeon, we tend to focus on like the high resourced, big private schools where there's a lot of money that we can tend to get something out of. The problem is kids in the inner city and kids in rural areas that play field hockey and baseball and run track, they have injuries too. So what we've been piloting is basically a virtual athletic team coverage. So athletic trainers are highly skilled, highly capable individuals who really don't need me physically there. But what they need is my guidance, my clinical acumen, my experience, and all of that can be done virtually. So what we've done is have athletic trainers and other folks on the field, and then myself and other physicians can be at home in front of 10 different screens, covering 10 different games, managing expectations, talking to families, talking to athletic trainers. It's actually way more efficient and effective than me working in the operating room all day and going to stand on the sidelines for a high school football game in the middle of November. It's 40 degrees. Probably not 40 degrees around here, but where we're from, it gets pretty cold. And that becomes quite burdensome for us. So doing something like this gets more people involved, more people interested. It still gets the care, the guidance, and information to where it needs to go, but it can be done in a way that kind of benefits all stakeholders. Physical therapy, Lauren has touched heavily on telephysical therapy. This slide doesn't really it's not about that. It's more so about killing two birds with one stone. So my post-operative patients all go to physical therapy. So rather than them going to physical therapy and then to my post-operative patient visit, we do it all at the same time. So mom or dad or whoever on a tablet, their phone, while we're at physical therapy, the physical therapist will be my eyes and ears. I can have them palpate the joint, arrange the joint, look for effusion or swelling, look at the wound. I can answer the physical therapist's questions. They can ask me questions. I can ask them questions. It's a nice little multidisciplinary conference, whereas in the traditional setting, the therapist will send notes and fax notes and all sorts of stuff that I may or never read. They tell the patient to ask me something, and by the time they come to see me, they forget. Or I tell them to ask the therapist something, and they forget. So this is actually just bringing everybody together. And I'm not even sure how I dawned upon this, but we just started doing it probably one day about 4 or 5 years ago. It's worked out very, very well.
From a workplace standpoint, do you block like in your days, like on Tuesday, Thursdays, I'll connect to the PT, or how do you do that?
So when I first started doing telemedicine, I was new, it was a little clunky, a little cumbersome. So I did it either in the morning before my in-person clinic or at the end. Now I just kind of do it interspersed in my regular clinic. And it'll be a slot. It'll be a clinic slot. Like Johnny has a post-op visit and it's telemedicine. And he just would have scheduled it at the time he was a physical therapist. That's just how I do it. So I'll be in my clinic doing whatever I'm doing. I'll go in my little cubicle, I'll pull up my screen, I'll talk to Johnny, who instead of being at home is at his physical therapy appointment.
Who manages that coordination between when his physical therapy appointment is and then your schedule?
My secretary. Yeah. We started doing it in our own physical therapy centers. We have a bunch of physical therapy satellites, so it was easier to do it that way. But now we do it forever. We just coordinate that with the mom, and my secretary handles that.
Okay, cool.
So this is something that's very near and dear to my heart. So we get a tremendous amount of transfers from smaller community hospitals, from rural areas, and invariably people show up to us that don't need anything from us. Or if they do, they don't need anything from our ER. They need it from me. But the gateway into the hospital system is usually through the emergency room, as you know, can be very expensive. So this is a real case. It's hard to real x-rays, but it's the same idea. So there's a kid, he's 15, football player. For those of you scoring at home, that's a medial condyle fracture. It's mildly displaced, they need surgery. He goes to an urgent care in his local town. They realize he's a child, he's a huge swollen elbow. They don't even take x-rays. They don't even really do anything. They send him to another urgent care. That urgent care gets x-rays. He's like, oh my God, you have this unstable elbow, needs surgery imminently, it's blah, blah, blah. So they send him to the local emergency room. You see where this is going. So he goes to the local emergency room and they're like, oh yeah, in fact, you do need surgery. In fact, you do have this fracture, but our orthopedic surgeons don't feel comfortable, blah, blah, blah. Go to DuPont. So he comes to DuPont, not to really get any significant high level of care, right? The second year ortho resident wakes up at 2 a.m. or whatever, saunters down to the emergency room and sees the patient who's already swollen. It's, stabilized per se. It says, oh, yeah, this is a medial condyle fracture. It needs surgery, but we'll do this as an outpatient. They send the kid home. So you can imagine, as a mom, they have 5 children. He's like number 3, right? She's shuffling all this around. And when he was at that ER, one, they would not let mom drive. I knew he's 15, he's a football player, he's in a splint, he's dying. They would not let them drive their own vehicle because they need surgery. We'll say they don't want to be liable, that he would be in his own car and fall out of the car and break his elbow worse. So they put him in an ambulance, which you can imagine is very expensive. Oh, and by the way, when you show up in an ambulance, how do you get home? Because your car is in the first emergency room. So needless to say, mom was very upset. She refused to pay any of the emergency room bills at our institution. It became a whole thing. But in actuality, it wasn't our fault, right? We're just doing our jobs. But you think of the pain this kid was in, right? He's gone to 4 institutions. He's sat in 4 waiting rooms. He's checked in 4 times. He's got his vitals checked 4 times. When you come to our ER as a transfer, you're not a VIP. You're just getting in the back of the line with everybody. The fear and anxiety is 15. It's like, oh my God, it's the middle of football season. I have this injury. Am I going to be able to play again? And this and that. Do I need surgery? And the expectations everywhere. There are people who aren't ultimately going to treat him, telling him what's going to happen to him, which, as you can imagine, does not coincide with what actually happens. So that roadblock in mom's mind, okay, it's an emergency. Okay, this. Okay, we're going to be overnight. We're going to, oh, wait, going back home. I live 50 miles away. What are you talking about? You know, in the time. This took 9 hours of their lives. Mind you, I think it was after school hours, so nobody was at work before school. The mom has 4 other kids, that she has to shuffle around. And by the time they get to us, it's like 2 or 3 in the morning. It happened Friday night, right? School and resources. Every single institution is doling out resources. It's not providing anything to the patient, right? The first 3 organizations basically looked at them, evaluated them, and just kind of sent them along their way. So imagine a world where, money. That's the big one. Here I get into my soapbox and I forgot about the money. So there are co-pays being paid, insurances are being billed, ambulance fees are being charged. Everybody is making money. So
I have to ask.
Yeah.
It's Friday night at the football game. This happened Friday. So did he actually get to have surgery on Saturday morning, or did he have to wait till Monday?
He had it. We'll get to that. But
Okay.
this is not an emergency surgery for
Right,
us.
but-
So
yeah.
I wasn't on call, but if I was on call, I'm not coming in and leaving my 3 kids on Saturday to do this. Why don't we just do it Monday morning when we have time? Yeah, so they were going to do it the next week. They actually wound up going to CHOP, which is our competitive children's hospital, because mom just, she was told it had to be fixed. She was not accepting no from it. So they went and had surgery over. So back to the soapbox. So imagine a world where you can take my knowledge and my guidance, and my experience to any one of those places. I could have told them in 5 seconds, so the kid in the splint, give him some pain meds, here's our office number, send him home with his own car, have him call that day, we'll talk to them. And I can explain things. I can say, listen, it's less likely to need surgery, likely to be able to get back to football in this amount of time. We can do all sorts of things and just obviate this whole inefficient, chaotic process. And to be honest with you, this only came to my attention because the mom put such a huge stake in it. I know that the chair of the ER who reached out to me and was like, hey, you're into telemedicine, what can we do about this surgery? So this happens every day. Hundreds of times a day, all over the country. Nobody really says anything because everybody's getting paid. But in actuality, we're shooting ourselves in the foot because you're like taking 3 steps forward to get paid and taking 2 steps back because you're wasting all of the time and resources. So being the nerd that I am, we decided to write this up. We're waiting to hear back. We submitted it as a manuscript to all those journals. But we basically looked at around 400 patients in a year or 2 that were transferred to us from outside hospitals. And what we found is that 30% of them did not need to come to the ED. So it's not that they didn't need to come to us. It's just that they come through the emergency room and they don't actually get anything in the emergency room. They don't get an aspiration, they don't get a reduction, they don't get an IED. They're just kind of moving along. And as you know, emergency rooms are very expensive places to just, and what we found on average was 9 hours of time. The transfer costs and the ED visit costs were through the roof, and we're now trying to put this manuscript. So specialist consultations is another big thing that we like to do. So as you know, our patients often go to other places, right, before they come to us. The ED, urgent care, but the big one is the PCP office. So most moms and dads with little ones hurt their knees and whatever, they're not big catastrophic injuries that need emergency. Everybody, for the most part, goes goes to the PCP. The PCP is there. Most pediatric people, I don't know if there's any pediatricians in the audience, but most pediatricians, my ex-wife is one, they are not trained in musculoskeletal care. Their residencies are 3 years. They get like 3 weeks of orthopedic care. So when they're in practice dealing with sick kids, and then these kids come in, they get a little overwhelmed, they don't know exactly what to do. So to be able to provide consultation at that point of contact is key because, again, we can teach the pediatrician, we can manage mom and dad's expectations, we can help navigate and guide the patient through their journey of their problem. And a lot of times they don't actually have to come and see me. They just need my stamp of approval to look at an x-ray, to talk to them, to answer questions. Because ultimately, yeah, most orthopods want referrals from pediatricians and primary care doctors. But actually, they come to see us. We don't ultimately do anything other than insure them. And again, it's money, our clinics are full, so nobody says anything. But there has to be an easier way. So we do this whether we direct to the PCP. Sometimes we do it in a clinic where it's just a PA, an APN, or even an EMIT, where they're doing things like providing DME. So they're putting out a sling, they're taking out sutures, they're cutting casts off, they're putting kids in boots. All of those things, you don't have to go see an orthopedic surgeon, because you hurt your wrist and you need a wrist brace, E-consult, so this is something that's very big that I've been doing for several years now. Basically, it's the idea of PCPs having patients in front of them, sending some sort of message, quick blurb with medical records and x-ray. These are with private companies. We don't necessarily do that in our institution. And a nurse or some person will triage and route that to the appropriate specialist. I'll get an email or a text. I'll respond at some point within 24 hours and send it back. And then the PCP can use that information to treat the patient. 90% of the time when I do that, it's usually have them do physical therapy, have them modify their activities, and have them rest. Sometimes I will say, send them to their local orthopedic surgeon. These aren't patients that are anywhere near me, wherever in the country. But my point is, a lot of times people just need guidance and reassurance. They don't necessarily have to ship a patient to go see an orthopedic specialist. And I'm up in the Northeast, so there are orthopods everywhere. But if you go out to states like California, Montana, Wyoming, all these big, huge states, where you have to drive 200-300 miles to go and see somebody. So that was more of the provider to provider aspect. So direct to consumer, this is some of the more fun stuff. I have this analogy. This is our hospital cafeteria. So for those of you who have found yourself in a hospital cafeteria, if you look at an individual who is in the cafeteria at any given point, and you ask them why they're there, why do you think they're going to be there?
They're waiting.
They're waiting. I was going to say because they're hungry. You guys are a step ahead. So my point is, just like you can't look at everybody in the cafeteria and assume they're hungry, the same thing goes for patient care. So I often find myself in the cafeteria for a whole host of reasons. And I call it the jobs to be done theory. So Hayden Christensen is from Harvard Business School, and he really touts this jobs to be done theory that you buy services and buy products to fulfill a job. So basically, when you're in the cafeteria, you may need food, but you also need a drink. I have meetings in the cafeteria. Sometimes I need to use the microwave. I need utensils, plates. I need to find somebody who's in the cafeteria. Our balcony or patio, you have to go through the cafeteria to go outside. So my point is, if I stood in the doorway of the cafeteria and I gave everybody a cheeseburger, I'm going to make a small percentage of the people coming through there satisfied. The exact same thing happens in healthcare. I can't look at every single kid that comes to me with knee pain and assume they're all coming for the same reason. There are various reasons why people come to see us. A lot of times the provider told them that they have with orthopedics. Sometimes they just need sports clearance. They had an injury at school, they sat out of gym for 3 days, and they're 100% better. They just need a note, right? Sometimes they just want reassurance. They're not even doing all that bad. The moms notice that they limped a little bit, so they bring them in for reassurance. Second opinions, athletic trainer or therapist is worried, they need an MRI, the list goes on and on. But until you really understand why people are in front of you, you can't ultimately help them. Problem is time. There's 35 patients, you may have clinic in the morning, surgery in the afternoon, and you got to keep moving. I can't stand there and pontificate with people as to all the reasons why they need me. So we came up with a pre-screening virtual triage process. My athletic trainer helped us with this. We have a patient with a problem. We used our video platform. We connect them with the athletic trainer. These were all brand new patients that I had never seen prior to the visit. And she would do everything that she would do in person. She would get their history, she would get the graphics, blah, blah, blah. But the key is that she spent 5 or 10 minutes pre-visit figuring out exactly what they needed. And she works with me, she knows my mindset, she knows what kinds of things I ask, so she can get a sense of, oh, this mom is crazy, she just wants to have this mom needs this. So when they do show up, I can tailor that visit specifically to them. Kind of like when you're on Facebook and Instagram, right? You don't get ads of things that I like, you get ads of things that you like. And it's the same thing. I want to make this person, this family feel comfortable. They walk in, hey, I heard from my athletic trainer that you're really interested in that mom. These are the 3 reasons why you don't do that. And I just start right off the bat. Or, hey, I agree, Johnny has a swollen knee. Let's go. But the point is, I know why they're coming, and I tailor that visit to them. And another thing that kills us is sometimes I'm not the right doctor for them. They need to see my spine partner. We get a lot of kids who have stress fractures in their backs or whatever, but they call, and part of the decision tree is like, oh, do you play sports? Oh, you do? You need to see Dr. Rotunda. They don't understand that pars defect and stress fracture in your lumbar vertebrae actually is for their spine people. So what we've been doing is we've been diverting people, sending them to where they need to go. Because you can imagine, you come into my office and we go through this whole thing for 15 minutes and I realize stress fracture in your back. Oh, by the way, I know you took off of work and took your kid out of school and you live 100 miles from here. Instead, that'll be $400, please. And that's what we do. And nobody really says anything because we can't. So that's what we've done. We, again, in the nerdball fashion, we kind of wrote it up and we basically, I won't bore you with the details, but we looked at the amount of time that these people were spending in the office with me, whether or not they were pre-screened. We found at the time, the overall time actually wasn't different, but the time that they spent with me, counseling and meaningful interaction was much, much higher, because normally somebody or myself would spend 20 minutes just figuring out why they're there. Now I can spend 2 minutes updating them as to what I heard about why they're there, and spend 18 minutes getting into the nitty-gritty of how we can actually come. We wrote this up, presented this at our sports medicine meeting a couple of years ago. Family conference, the cervical discussion is huge. There was a girl with an ACL tear. It was a Friday. Lots of things happened on Friday. And her surgery was the following Tuesday. And they had questions. I had already seen them. I'd already done everything. But they called me. I was, oh my God, stop the presses. We have more questions. Well, guess what? That particular day, Dad was put off. So it worked. The girl was at school, and this fine young handsome man is supposed to be me. I was off that day. I was at home doing work. So and the following Monday, I had a full clinic, and then Tuesday was a surgery. So there was no way that I could actually have a clinic visit with him. So the point is, did a telehealth visit. The dad was literally drinking on a golf cart, and he would stop after his shot, and he would come on the screen, and we would all talk. Everybody asked their questions. I answered their questions, and everybody went about their business. And that was a visit. You could bill for it, but ultimately, we did something that would not have been able to be done in a traditional sense, and also gave everybody exactly what they needed with little inconvenience, right? Mom was typing at work, and she just kind of came on. I was at home, whatever. Dad didn't have to stop his plans. The girl at the school it was later in the afternoon. The school was over, so she was just in the parking lot talking to us. But the point is, you can't always do that in a traditional sense. Second opinions is huge. A lot of large academic centers are doing this now. We're very slow to get along that, trying to do a lot of second opinion work outside organizations. And again, it's the same idea. People have been seen, they've been packaged, they have images. All they need is just somebody to reassure them. You don't have to get up and leave your house and take your kid out of school and come wait in my waiting area for me to look at your MRI to tell you, oh yeah, you do need surgery. That doesn't have to happen anymore. We can do that very quickly, very easily. And again, you can move knowledge and information, you can move images as opposed to move people. So this is some of the more futuristic stuff. Careport MD is a company that's based up near Wilmington, partnering with Safeways and Acme's and different things. They have these futuristic photo booths with all these peripherals and streams. But the bottom line is we're trying to create an ideal world where you can get healthcare wherever you happen to be. The old adage of, oh, I'm going to build it and they will come doesn't necessarily have to happen. We want to be able to do whatever it is we're doing, wherever we're doing it, and get the healthcare that we need. Our award-winning librarian is in the back, young Nick, who received his award at dinner last night, is touting this in libraries. So you can imagine where the future is going. And again, this is the Acme where the Careport. These are schools, churches, gyms, restaurants. This is the way for the future. And then doing things at home. Take care.
I have to run, but I will be in touch with you.
No problem.
Thank you so much.
Take care. This is also bringing things to the home. So I don't know if any of you have used any of these mirrors. I've seen them. I've actually never utilized it. But these are like exercise type things that you can imagine. Rather than seeing yourself, you can also see a physician or a provider or some sort of person watching you, or a physical therapist who's watching your gait and analyzing things. So these are definitely very important headways into what we think happens here.
It's like the Jetsons. It is. Little video on the screen.
Very exciting. Speaking to the care wherever you are, this was one of my favorite examples that I had with a young client in telehealth. He was thankfully, he's still in his same state, but they went off to the Hamptons, like some New Yorkers do in summer, to their summer home. Lucky them. And normally we would do a pause in their care for however many weeks they're gone. And that's always unfortunate because they might be making a lot of progress that might stall a little bit. But instead we were able to continue with the care visit. And not only that, when I got a hold of the patient at the start of the session, the mom was, oh, I'm so sorry, I got to come out the pool. I'll be right there. And I said, wait a minute, let's keep them there. He's having a good time. Let's make this an aquatic therapy session. And it had ended up being super successful. He was highly engaged, as you can see. He's like having a blast. We did all sorts of like sit-ups on the edge, different like strokes, different jumps, and really made it productive. But I really enjoyed it, and so did he, and he got a lot out of it from a clinical and functional standpoint. So this is not only a continuation of care that telehealth allowed for us to have, but it was then next level of in a really unique environment that So to speak further about just the actual advantages of the technology in our care, I think it was a super amazing example with the virtual reality. But even as Alfred was mentioning, videos, just making educational content that is, provided in an asynchronous manner is very efficient for the providers and for the patient and family member who, might want to check it after they're done with their golf game or, at 1 a.m. because that's the first time they got a break that day, or what have you. And it really helps hopefully give them even more content to understand care. These are a couple options that I put together that have great digital movement analysis. Some, apps where you can put a pin in the axis at a joint and use the, follow the lever arm of the body, whether for exploring weightlifting techniques or actual athletic sport moves. There's some great tracking technology devices that Whoop I really like. There's Spark Motion and then video. Just as some choices out there that are great for this, but they're finding more course. And within these, there's some paid, there's some free, and then back to one of my niche areas of pediatric care. These are some fantastic websites that you all may have heard of before. One's Pink Oatmeal. It's done by a physical therapist, a pediatric physical therapist, and there's Inspired Treehouse. It's a OT and PT. And both of those sites have a vast amount of free content, blogs on different topics, graphics, ideas for treatment, intervention, assessment. And what I love is that there's information not only for the providers, but also for the parents and the kids. So it's just like covers everything. When I first got into the pediatric space, this was really helpful for me. The Go Noodle and Boomers are really cool platforms as well that have just really fun, like there's a lot of songs, there's a lot of just movement-based activities that both have the same goal of promoting wellness, both physically and mentally for children in a way that they really enjoy, like super fun colors and graphics that are free for parents to pull up on their kids. And then within the sessions too, just utilizing technology in a way that we might not have been using as much, or just screen sharing or showing things that we might not have used in a clinic, where the patient is in their home, which is the most probably the most meaningful space that they navigate. So getting an opportunity to have them make a show and tell moment and really connect with you as a provider, it's important so that they feel like they know you, they trust you, and they enjoy being with you. Incentivizing them, maybe goals, maybe having a sticker chart you make on a graph, you screen share, different games that I'll show you in a moment, and then even just a messaging space for questions I've used with teenagers as well. You can use these same things with adults, maybe on a less cheesy level, but we have to remember that we were all kids at one point and we still want to have fun. And I think incorporating a playful aspect to care is really appealing to all ages, making it fun. So we know that patient-centered care is one of the most best aspects of outcomes. So this is an example. This is actually from the Inspired Treehouse website, which I mentioned earlier. This was a free Google Doc that I have. Fun little like movement-based game for kids. And we try to do this movement, that movement, and then try it out, and we can show these and share this with them and do it. This one is a paid one from one of the other sites, the mail one. And these can actually be mailed or used digitally, physical or digital cards that have all sorts of different games and really fun content. Quick.
Yeah, so we just have about 10 minutes left, so I'll just breeze through these. So basically, in terms of asynchronous video content, this is some of my cheesy YouTube videos that I provide to my patients. So you tore your ACL now. So you can imagine every time a kid or a parent or whoever finds out that there's an ACL tear, those visits are long, there's a lot of crying, there's a lot of emotions. They're all the same for the most part. So now I create a video that goes over from soup to nuts, every single aspect of how we take care of kids with ACL tears. And I send it to them. They watch it, they go through it, they share it with their grandma, they share it with their friends, their coaches, whoever. So when they come to the visit, it's just a much more meaningful visit because they know all the nuts and bolts. So when can I go back to school? Am I going to be admitted to the hospital? Am I going to be in a lot of pain? We get through all of that. And then we really just focus on the true meaningful counseling that goes on. And then I have other videos just about different things about sports specialization, Severus disease, heel pain, youth sports in general, how to keep your child safe and healthy, how not to play around, how to break it up with different sports, how to have a couple of days a week off, how not to play for multiple teams. Informed consent is very key. So it's the same kind of thing. Every day I go to do surgery, I have to get consent, and that's fine. But it takes a lot of time, and there's a lot of commotion that's in the preoperative holding area. You can imagine there's screaming, there's kids crying, everyone's hungry, everyone's anxious. The preoperative holding area is actually no place to get consent. People will sign anything that you put in front of them, right? Showed up, so that's consent in itself. But we do want to make sure that they understand what we're saying. And oftentimes it's hard to do in the clinic because they haven't decided that they want surgery yet. See them. So again, I made these videos, I send it to them before, so when they do show up at pre-op, all I do is say, hey, do you have any other questions? Sign here, I mark their in, and I leave. That has a lot of other downstream effects as well, because for any of you who have or been in pre-op building recently, there are lots of people who need to get that patient. There are nurses, there's anesthesiologists, there's nurse practitioners. And unfortunately, when the surgeon shows up, everybody stops. And let me barge right in front of the line, and I stand there and articulate all my stuff. And everybody else can't do what they need to do. So what does that do? It often creates a delay getting back to surgery. And there are metrics of how soon you get to surgery, the delay times, times in 3 hours. So my point is thinking outside of the box and really thinking about the effect of the things that we do as providers, the words we say, how we say it, where we say it, is really key. And I'm not saying anything different. I'm just separating it in time and space and changing the same workflow. And it makes my job easier, but more importantly, it makes everybody around this job easier. Discharge instructions is the same thing. When you're in PACU, your kid is recovering, vomiting, pain, you're just so glad to be with them again. Here I am not going to tell you how to put this brace on, how to use crutches, how to change it. They're absorbing anything. And then they go home and they lose the paper instructions. They call my office. And I get annoyed because my secretary is calling me about surgery. And it's a whole thing. So now we provide them with all this information. People digest information, especially the kids, live. So if the parents, whoever get the stuff, you send it a couple of days in advance at their leisure in a nice, quiet environment. They can digest it, they can read it, they can answer questions. And another cool thing is that when we're actually doing the surgery, is that the patient's parents are sitting there doing nothing for like 3 hours. So we also give this sort of stuff during that time period, because rather than sitting there watching Netflix and roaming around the hospital cafeteria looking for a cheeseburger, they actually get some useful information. So now when the nurse in the recovery room is going over all these things, at least mom or dad has heard it, it's primed a little bit. They still may not remember everything, but it's a much better use of their time. Student education is the last bit. So we all are mentors, we're all leaders. We all kind of help those who come behind us. So I've made some videos about how you shout at the doctor, some things like that. My kids watch these YouTube videos and laugh at me because they say it's cringe. But I still put it out there and people can digest it. So last but not least, we'll end with this. As you all know, telemedicine is a tool. It's not for every provider or every patient. I wholeheartedly agree that it's going to augment, not replace the clinical care doing, but there are lots and lots of beneficial ways that we can augment the care that we provide. And you come to a conference like this, a lot of it is about remote patient monitoring, direct to consumer, but as you know, there's so many other ways of video technology, video digestion, and also provider excuse me, you do have to be flexible, as you know, you do have to be patient. And you wake up one day and start doing all of these things. This is about 6-7 years of my life that I've piloted, tried, and failed all of these things. And I think, in musculoskeletal care, orthopedics, we have a lot to learn from other specialties, other providers, the folks in the emergency room, neurology, and primary care. They've been doing this for decades. We're just there hitting it in high school. Being an innovator can be lonely. I don't know how Lauren feels, but as an orthopod, there are no orthopods here, right? There's not a lot of people kicking and clawing and clamoring to be doing this stuff. We are so focused and so reaching in the things that we do and how we make money that it's very, very hard to change that paradigm, change culture. But I believe in it. It makes me feel good, so I still do it. I haven't quit yet. But I'm still fighting the good fight. This is my 6th year coming to Matrix, so you know that I'm still working at it. And have fun, stay well, and thanks for listening.
Thank you, everybody.
Yeah, absolutely.
Thank you very much, Dr. Hegel and Dr. Tanda. That was a wonderful presentation. I'd like to open the floor for questions. We have about 4 minutes left, so we have some time for a couple of questions. I don't have any that have come through online at the moment. So if we want to take some from the in-person audience.
Once you started doing your virtual visits, I assume the hospital already had a platform.
Yeah.
So you were just able to do that platform.
Right.
Through your EHR.
The question was, did my hospital already have a platform that I can start using? And that was very, very key. So you can imagine if my hospital didn't even have that,
Right.
I just woke up and said, hey, let's do telemedicine. that can be hard, and that can be an uphill battle. Forget the whole orthopedic side of things. You have to just now get the infrastructure.
Yes.
So I was very fortunate that our hospital had a director of innovation, a director of telehealth, a managing director. I mean, they had a whole setup. So it was like kind of turnkey. I just started. That was very, very helpful. I couldn't think about that.
I have a question.
Yeah.
So you've made a lot of innovation, a lot of change in your own workflows and your own scheduling and that sort of thing. I'm assuming that some of that has translated to your colleagues and others, like, I mean, that they've adopted those things.
Some of it.
Some of it, right?
Yeah.
So my question is, what are you most proud of to be able to say, that's not just me doing it as a vigilante, but like that has become standard of care in your hospital or
Yeah. I mean,
all of that?
I started on my own. And to be quite honest, I'm not a very patient person. And when you work at a large academic health center, it's like trying to move a cruise ship. I'm more of a speedboat kind of guy, or a sea-doo or a wave runner. I like to have an idea, like I want to implement this tomorrow. It doesn't go over that way. So I had to just kind of start, like in orthopedics, I was trying to get everybody on board. Nobody was interested. So I just started doing it on my own. And by kind of diffusion and osmosis over time, some people were kind of getting on board, but I will guarantee that most of my partners are not doing all that stuff. They're mostly doing direct to consumer post-operative visits. And that's something, but I come to places like this because I get that camaraderie and I get that buy-in, and it makes me feel really good to be around people that believe in it. And I can try my hardest to convince everybody in academia or in my particular center. But at the end of the day, I just go where the action is. So I go to telehealth. I link up with people like Lauren. I go to telemedicine textbooks with all of our contributors. And I just do what I can do. It would be nice to bring everybody along with me, but at the end of the day, it's just nice to do it.
That's fair. Find out that, looked at this as you started the visits, patient satisfaction.
I didn't look at that specifically. It's hard to say. So I'm the chief of sports medicine there. I've been there the longest compared to the other sports medicine surgeons. I do have kind of the biggest following patient base. So it's hard to tease out if some of that is because I do personal visits or because I'm a nice guy or whatever. I don't know. But that would be something interesting.
I know from a healthcare standpoint, that's where patient satisfaction
Yeah.
is a huge talking point, but I would think just in the stories that you told and like the 3 ER visit, urgent care, ER,
Yeah.
just from that standpoint, being able to bring time back to mom and dad, not having to leave school, not have to do all of those things, I think absolutely good for the patient.
Yeah, I mean,
Overall.
I started when I was talking about what I was doing, it was more specifically telemedicine and providing guidance and doing things like that. But what I've actually leaned more towards is really being like a telemedicine triage navigator kind of person. Even just the other day, I had a nurse that works in our hospital. They had a family friend who broke his wrist. They were seen elsewhere. They had X-rays, whatever. They were supposed to. They were going to go see someone, but they wanted my opinion. So I called them, on Saturday before I came here. I chatted with them for like 10 minutes. I texted some of my partners, and I got them a visit yesterday, Monday. I don't even know what happened, but my point is, from an entrepreneurial perspective, that's something that I've been dabbling in, is how can I navigate people through the healthcare ecosystem? And it's a lot easier for me to just provide some minimal guidance and information, get them to where they need to go, as opposed to be their actual treating physician, because that's liability, you have to document it, this and that. When I was talking to this dad on the weekend, I was with my own kids, I was playing tree hockey and just like talking to the dad every now and again. And that's where I would like to see like what I do. I love doing surgery. It takes a lot of energy. I have little kids and single dads. I can do things to help people move through the healthcare system, which I think is equally as valuable as operating on it. And ultimately, at the end of the day, an injury is only treated truly, like, really set the stage for how that injury is going to affect their lives. You know, when you do surgery on them, it takes an hour or two, they're asleep, and they don't know, but they want to know, when can you go wrong, when can you try this, when can you do that. That is the true value of what I provide. I just don't get paid to do it, right? And that's the balance. And I'm not a finance guy, I'm a policy guy, just the wrong guy. I don't know how to really reconcile that, but that's where personally I want my trajectory to go. It's really how I can provide value, be compensated, help people, still just get them to die life. Hopefully I'll get next one.
Well, we are at time. So I would like to thank everybody again for attending this session. If our AV person can put up our evaluation slide, I would love for everybody to be able to give an evaluation of this session. You can do it on the virtual platform. I realize I didn't introduce myself at the beginning, but my name is Whitney Wiggins, and I'm from the Health Resources and Services Administration, Office for Advancement of Telehealth, and it's been an honor to moderate this session with you all. Enjoy the rest of the conference. There's a break, and then the closing keynote session will be at 12 p.m.
Thank you.
Thanks.
Thanks, everybody.
Thank you, everyone.
Thank you very much.
Thanks for sticking in there.
Yeah.